Hi, Dr. Ranjit. So, thank you for the podcast, and I think the audience will like to know about your portfolio. Like, what do you deal with? I know you're an extremely well-renowned andrologist from Dubai now, earlier in Miami. So, please go ahead and introduce yourself.
Yeah, hello. So I think andrology is a specialty that deals with male reproduction, specializing in both sexual dysfunction and male reproductive disorders. I started off my career in Miami, but now I've shifted to Dubai. And at Jumeirah American Clinic, I'm a consultant urologist.
So, what do you specifically deal with in infertility in Dubai?
So, specifically in Dubai, infertility is actually very similar practice to what we saw in Miami. You visited us in Miami.
Yes.
It's a wide spectrum of patients, all the way from oligospermia to azoospermia. The one big difference in Dubai that's not true in the US is there is no use of donor sperm. It is not allowed both in the law as well as in the religion, and so therefore the quest for both finding that sperm, quest for trying to improve sperm parameters to try and get more sperm, I think is a lot more here in Dubai in the Middle East compared to the United States. How about in India? You have the option of using donor sperm, and when do you introduce that conversation?
So in India, actually, we have donor sperm, and there are many patients that even don't have the concept of the own sperm. So many a time, the patients are actually counseled for donor sperm, and they come searching for us for their own sperm. So the situation is actually a little bit reversed. Now it is becoming better. So now in India, the idea, the awareness about the micro TC procedures, etc., are now coming up in a big way. So now we do discuss about donor sperm with the patient, especially when there are failed treatments earlier, or whenever there is a question about affordability, or when the couple is very clear that they don't want a defective child. So that is the situation specifically when they demand for a donor sperm. Otherwise, we always have the options listed, and their donor sperm is an option.
Got it. So obviously, micro-TESE is a gold standard for treatment of patients with azoospermia who have a production defect. Azoospermia can come in two varieties. One is when they make a lot of sperm and it gets blocked along the way, and for that, simple needle aspiration procedures are sufficient to get sperm. Whereas in patients who don't make enough sperm, there could be still some sperm left in the testis, through which micro-TESE should be done for those as the first line treatment for patients who don't make enough sperm in the testis. What is the landscape of micro-TESE here in India? Do a lot of surgeons do it? Are they trained in the microsurgical techniques? And what happens to majority of the patients with non-obstructive azoospermia who don't want to use donor sperm?
Many a time, the non-obstructive azoospermia in India goes through a testicular sperm aspiration. So beyond testicular sperm aspiration, there are not many centers that do offer micro TC. But again, the landscape is now vastly changed. In Chennai, we have centers now doing micro TC routinely, and the patients now have the awareness that micro TC is the treatment option for specifically non-obstructive azoospermia, which is worse. When they know that the previous testicular sperm aspiration has not worked, the patients now know that there is an option called micro TC, and there are centers now to go for micro TC. So that situation is now changing.
No, it's very important, right? Because a lot of patients think that they're getting micro-TESE. They're being told that they are undergoing micro-TESE, but somehow, micro-TESE is not done. I think when you define micro-TESE, for at the least, you need to use an operative microscope. If doctors and surgeons are using loupes, then that is not a micro-TESE. Number two, the testis should be bivalve, mostly in the longitudinal axis, on the transverse axis, sometimes rare cases in the longitudinal axis. And tubules need to be searched for. Differences in the tubules need to be identified. So only when you use an operative microscope, bivalve the testis, and search for differences in tubular size and architecture, I think you can tell a patient that they have undergone a micro-TESE.
Yeah, so that situation in India is slowly building. So as you rightly mentioned, people were told that micro TC is being done, but it was maybe an open TC. And now with the change, with the availability of the equipment and with the expertise building up, especially when we get trained from US, etc., that is where the expertise is now coming in India in more centers to offer micro TC. We do have micro TC being done in India for a long time, but now there are more centers and it is getting accessible for everybody.
What do you do for patients who have now failed micro-TESE? Do you often do it along simultaneously with the egg pickup, or do you wait to do the micro-TESE to answer the question of sperm, no sperm? Do you use donor sperm as backup for these patients? What are some of the thought processes?
Yeah. So basically, since I came to Miami to observe the practice, in India, we actually do a simultaneous synchronous micro TC with egg pickup. That is the most common plan which is being offered nowadays. There is a shift between earlier they used to do the micro TC, and if the micro TC is negative, go for donor sperm injection on the same day. But now that concept is changing because the IVF labs are more confident of freezing the eggs now. So there is a shift there where we discuss with the patient that since the rare sperm, freezing that may be little, like to freeze it and use it may be difficult. So go for egg retrieval simultaneously. If the micro-TC is successful, then it's all good news. If it is not, then we give the option of freezing the egg, or even we give the option of using the donor sperm for 50% and the male continues his treatment, and then we go on like that. So there is a change there.